Welcome everyone to this phenomenal Facebook watch party. My name is Alison Schofield and I am a tissue viability clinical nurse specialist. I'm really excited to be joining you this evening to talk about leg ulcer management. If you haven't seen one of our previous watch parties, then I'll explain what it's all about. So I've pre-recorded a presentation for you, and so we'll watch it all together and then we'll chat about it in the comments. I will be answering your questions throughout and joining in the conversation, so please don't be shy, just type in any questions that you have and I will try to answer as many as I possibly can. I want to thank Flen Health for putting this event on this evening. Flen still have a number of these hand hygiene tools to give away to nurses who would find them helpful, so you can open doors and things without having to actually touch it. It's fabulous. So you can find out more about this at the end, so it's definitely worth staying around to find out more. So let's move on to the presentation itself, which is leg ulcer management. So the learning objectives for this evening are to recognise aspects of treatment planning with patients at the centre, how to manage the wound and the surrounding skin, and we'll do that using the TIMES wound assessment framework. We'll look at finding a suitable dressing and a skincare regime. We will see when to use and not to use compression, and we'll explain the ABPI through Doppler. What type of compression should we use? What compression do we utilise? And we'll look at the red flags and when and where to refer to. We'll also briefly look at how to address non-concordance and health coaching, so that's supported self-management. So just to recap, so hopefully you watched the last watch party, which I presented around leg ulcer assessment. So it's all around a holistic approach, so it's the whole patient, remember, not the hole in the patient. So that accurate assessment that we've completed is essential to ensure that we have some appropriate and realistic goal setting with the patient. So the wound assessment is the most essential part of wound management. We can't go on to managing the wound until we've done that full assessment initially. So just a reminder of the best practice statement definition of a leg ulcer. This is defined as an open lesion between the knee and the ankle joint. So we're talking about venous leg ulceration. So this occurs in the presence of venous disease and it takes more than 2 weeks to heal. Particularly in patients with venous leg ulcers or venous signs, the assessment and treatment of that new lesion to the leg, however that is caused by, it might be a scratch, it might be a knock to the leg, it might be an insect bite, but we need to start treatment as soon as possible to get the ulcer healing quickly. So with the management, we need to be looking at our treatment plans. So this involves discussing and fully explaining to the patient about the diagnosis that we've made or our specialist MDT teams have made for the ulceration. We need to be offering a referral to the patients to vascular, so they can have interventions such as duplex scanning. So if it's appropriate for this patient, it may be that they can have some surgical intervention that will then rectify their venous conditions, and this then will prevent it coming back. There's been lots of research around this and the vascular teams are really coming on board to enable this process. We need to make realistic goals and aims with the patient at the centre. We need to form a care pathway, a treatment plan. We want to choose the most suitable type of compression that the patient can manage. And we need to decide on what type of dressings we're going to use from our formularies. A skin care pathway is so important because we need to look after that surrounding skin and we need to prevent any further breaks to the leg. We want to work with the patient or carer on that supported self-management if it's appropriate to do so. So there is assessment around that too. And we want to give the best advice and information, so that may be in the form of leaflets. There are videos out there. I use patient passports for leg ulcers, and also patient diaries are a great thing, because then they can share with you their feelings and how it is really affecting them, and their goals and aims too, which may be very different to ours. So the wound itself, we're going to be looking at the assessment using the TIMES framework. It's a fantastic assessment, is this, and it looks at all aspects of the wound. So we've got the T for tissue, so is it non-viable, or do we need to prepare it in some way to make it much more viable for wound healing to take place? Is there any infection, inflammation or biofilm present that we need to address? And what's the moisture like? We know wounds heal in a moist environment, but do we need to add moisture for that autolytic debridement to take place, or are we managing the moisture because there's too much of it in Exudate? What's the edge of the wound like? Because the edge of the wound contracts together in normal healing, the epithelial cells form, but if there's any problems, then this cannot happen. So we need to be checking what's going on there. And then the surrounding skin. So when we're talking about suitable dressing regimes, you know, I have a formula in my trust. We share it with another trust. It's quite advanced. We use prescribing FP10. Some of you will have systems in place where it is there's a total purchase, so things come into your stock. So we probably all use different types of ordering systems for our products, but it's important that you look to your local formularies and speak to your specialist nurses there when you are looking at types of dressings, because some that I might have you won't have, but a lot of them do a similar job. And the thing is, and they come in different categories of what they do, and a dressing doesn't heal the wound, remember. The body heals the wound, but there are certain symptoms and things that we need to manage, and we can do that with good dressings to aid the wound onto its most viable, best pathway to healing. So we're going to use that TIMES framework to form our treatment objectives. So we're going to look at, does the wound need debriding? We want to reduce any bacterial burden, of course, so we want to prevent and manage infection. We may have to give hydration, or we may just want to manage the excess exudate. Skincare, always so important, and dressings, what we can use under compression. And also that supported self-care. Is the patient going to be able to manage with products, or their carers or families, if it's appropriate for them to do so? So wound bed preparation is a framework that promotes a healthy wound bed through forms of debridement. So this will provide a therapeutic cleansing of the wound. It will disrupt any biofilm present, and it can also remove any necrotic or non-viable tissue. There are different forms of debridement. So one of them is mechanical. So we do that through cleansing, and it might be that you use monofilament pads, just so the fibres in there then they will pick up this kind of the slough, the debris in the wounds, and then remove it during that cleansing type process. We can provide a moist environment. As I said, we know from the research, which has been there since the 1960s, that wounds heal best in a moist environment. And this is, like autolysis. Our bodies naturally go under an autolysis program. So we have all this cellular activity inside. We have what I call the little Pac-Men coming along to eat up all the bad elements in there to give the wound a better chance of healing. So when we're providing that moist environment, then we're encouraging all this natural systems to occur, and then the epithelialized cells can migrate across the surface of the wound in a lovely granulation type tissue. Sometimes we need the dressings then to disrupt and moisten any slough or necrosis that is there. Larval therapy, so we've got our lovely little soldiers, and they are fantastic. If you've never been to the larval factory in Wales, then it's always worth a trip, because it's just absolutely fascinating. It's a sterile colony, and we can use them either free range or in their little biobags, and then they will act on the devitalized tissue. Sometimes it depends on your environment, where if for use of these, we can use them in patients' own home. I have done regularly, but sometimes due to cost, and it has to be an independent prescriber or a GP who prescribes these, and they're used quite regularly in the acute environment too. We also can have sharps, surgical debridement, but you must do a referral for this, because you have to have undergone a training course and competencies to be able to perform any kind of sharps debridement. You'll often find podiatrists, tissue viability nurse have these skills and competencies. And it may be that some patients need to go into theatre to have a full surgical debridement, and then we move on to products for wound healing after that. We want to reduce that risk of infection. You can see on the photograph there's a beautiful bright bluey green Pseudomonas type bacterial infection going on there. So we want to try and use, where possible, aseptic techniques as much as we can, and we give that advice and information to the patient and their caregivers. I know I'm a community nurse. I've been a community nurse for about 20 years, and it's like in patients' own homes, sometimes we have to use what's called a clean technique, because you might get the dogs and cats running around and things like that. So it's sometimes a bit more difficult than it is in the clinic or acute environment to use full aseptic techniques. We may be looking in our products to use antimicrobials, and this can be things that donate, such as silver or iodine, the osmotic effects of honey, and also we've got some which are bacteria binding, which on removal will remove the bacteria biofilm in that way. It's always good to do that cleansing type debridement first, so it disrupts the biofilm, and then any treatments we're using can then get through to address bacteria into the wound. So we want to observe for signs of clinical infection and treat in line with our formulary products. So we want to be aware as well that we have got an antimicrobial stewardship. So that is, it's worldwide, and so there's been such a big use of antibiotics that people are becoming so resistant to them. So we want to be aware of that. So we want to just use antibiotics in the appropriate way, and when we've got signs of that local to spreading infection. So this is an example of somebody with cellulitis, so that's a soft tissue infection, to be looking out for and sharing with our patients to be aware one of the red flags of signs and symptoms of cellulitis. So the skin will be very red, warm. It will be painful for the patient. The leg might be leaking. The redness is spreading. So this is the point when we need to be making sure that we have got some antibiotic cover for this. And then in the British lymphology guidelines, there's guidance in there around people with lymphedema and recurrent cellulitis as well, and about prophylaxis treatment. So have a look at that document. It's got some fantastic advice. Also, just to mention, and I think we did this in assessment around red leg syndrome, so just to be aware of the difference between cellulitis and red legs, that red legs can be a part of the venous disease symptoms, and it's like an inflammation of the tissues, and it will be often both legs that are red onto that mid-gaiter, mid-leg area, and we want to make sure that we're not giving antibiotics when it is red leg syndrome, because they won't do anything for that at all. So this is the wound infection continuum diagram. So this is an international publication, and so we need to be following this around bacteria, biofilm infection. So all wounds have some element of microorganisms within them. If you swabbed every single wound, it will show you that you've got some enteric flora in there. So we have wounds that we have contamination and we have colonization, and we can often see signs and symptoms of this. It may be that there's slough there, that there's a shiny wound bed surface, which may be biofilm. So we need to be vigilant with this, and when we need to be addressing this with our type of products and our moist wound healing. Then we move on to local infection, and this is when we're looking at our topical antimicrobial. So topical, that is our dressing type treatments, the honey, the silvery, etc. Only when we become to the point of a spreading infection, so think of those signs of infection to the tissue, spreading erythema, heat, then we need to be looking at systemic and topical antibiotics, antimicrobials, because then we want to be aware that we don't want this to turn into a systemic infection. So the patient would have a pyrexia, raised temperature, feeling unwell, and antibiotics are definitely needed at this point. So just be aware of over swabbing, because it's we just need to be doing these things when it's actually appropriate. So moisture, exudate management. If there's too much exudate, then this can damage the surrounding skin, the peri-wound skin. So we need to consider using products to address this. So it might be that it's a foam product, or it might be an absorbent pad or a super absorbent pad. So it depends on the amount and type of exudate that we're dealing with. Now, I know some of you will be asking this question: can we use super absorbents, absorbent pads under compression? Yes, we can. And I've heard stories sometimes of these pads being put in on the outer side of bandages. Well, that's like putting a nappy onto top of a baby's clothing. It's not going to have that effect. It needs to be direct to the wound and onto the skin for its absorbent properties to work properly. The compression will still be active, and as long as we're not bulking up too much, because that could reduce the type of compression. But also, if we've got a pad, we need to shape the leg as well, so we can use our wool and things like that to make sure we've got that nice graduated cone effect from the ankle upwards towards the knee. So our skincare, and this is just one of the most important aspects, is looking after the skin for that preventative once the wound's healed, and to stop ulcers recurring again, but also while we've got active ulcers, because we can get things like venous eczema and dermatitis and things like that. So we want to keep the skin really supple. So general care of the skin is just integral to this part of our treatment plan. So the peri-wound skin, so surrounding the wound, and outwards from that, we can use the emollients that we have on our formularies, and that there are many out there on the market. We need to use things that are in our cleansing, pH balanced, because we don't want to be drying the skin out further. So on the absolute edge of the wound, if we've got too much exudate and then we're getting that white macerated skin and it's becoming excoriated, then we can use the barrier type preparations. So that might come in the form of a spray or a cream, and that will help to prevent it, because it is a type of MASD, moisture associated skin damage, and we are reported on these now as well as pressure ulcers. So peri-wound MASD is a really important thing to be managing. This is the other end of the scale. So this leg, as we can see, is extremely dry, and we've got a build-up of that hyperkeratosis. So hyperkeratosis is just a hyperproduction of skin. So the skin is extremely dry, but then you can see to that sort of lower side, it's built up in very thick plaques. And a lot of you are dying to get the tweezers in there and give it a good pick. But if we have to be careful, because if we're picking and things like that, then it can cause trauma and bleeding and and ulceration. So let's kind of treat it with our skincare regimes. Sometimes when they're very thick areas like that, if you apply a hydrocolloid dressing on just to make it moist, and then when you come back next to do the next cleansing, it might be just that bit more moist to come away. So that's a little tip for you there. So this shows a leg, a foot that has got that hyperkeratosis, and how with a good skincare regime of using a monofilament pad in cleansing, because that can address these stubborn areas too, and the emollients then added on to add that moisture to the skin. But if we've got dermatitis, if we've got venous eczema, then it may be that we have to look to our topical steroids to manage this, because it might be a problem that's persisting. And do remember to utilise our dermatology colleagues in this too. So let's have a look at this together. What are the aims and goals with this patient? What can you see? What type of ulceration do you think it is? Look at the foot, look at the surrounding skin on the leg. So if you type in the question box now, and let's do a little assessment together. So can you see signs of venous disease? Is there any signs of arterial disease? Look at the position of the ulcer. What's going on in the ulcer bed? What can we see in there? How are we going to manage this? What do we want to do? What is, your ultimate aim and goal? So now we're going to talk about the compression. So let's just reflect back to assessment. So we know within venous disease, we have the job that the veins do is that they pump the blood back up to the heart and the lungs to get the oxygen and nutrients. They do this by the action of the calf pump. So when we move our foot and our leg, we've got a pump in our foot and then our calf, and that big muscle, and it squeezes the deep veins with that blood return. But if there's any damage to the veins, the valves inside become damaged. So when the blood pumps up, they don't meet together, and we get that reflux of blood. So it goes up and some of it comes back down, and then it overwhelms the perforator veins and then the superficial veins on the outer area towards the surface of the skin, and then we start to see that bulging of the ankle flare, and we start to see baggy varicose veins, and the walls of the superficial veins are much thinner, so they just can't cope with this. And then we start to see that overflow of things like the brown staining, hemosiderin staining to the leg, because it's byproducts of the blood that are doing that. So all these things, the lymphatic system, the edema, so this is what's happening. So we need to help and reverse this. Remember at the beginning we talked about the referral to vascular services. Do remember that, because some people can have that intervention to reverse this issue for them, but we do utilise the compression that we have. So within our assessment, we are going to do that ABPI through Doppler, and the ABPI will help form that plan of when to apply compression, if not to, and the type of compression and the amount of compression that we are going to apply. So we do this with that using, hopefully, with our handheld Dopplers, and I know there's automated Dopplers there. We have both in our trusts as well, so either or. But if you get an abnormal ABPI result, recheck with your handheld Doppler. You can listen to the sound, you can check the sound waves, and just to do a double check. It might be that you're unable to do an ABPI for some reason, because the patient it can only be in a sitting position, so that will affect the results, or it's too painful, things like that. So you can refer to your advice from Tissue Viability Leg Ulcer Service with that. So if it's abnormal, then we can consider doing a toe brachial pressure if you have those systems there. We need to check the leg for the clinical signs and symptoms. Remember, back to the assessment. And then we need to look at, is what's benefits are we weighing up here? Is the therapy of the compression gonna be advantageous to the patient versus the risks? So we need to be assessing like the sensation to the foot, consider any different pathologies, and if the ABPI results remain abnormal, we just can't complete them at all, then referring to your specialist services. If the ABPI is below 0.5, then we're considering that obviously that there's some arterial involvement here. So again, repeat the assessment just to double check. We don't apply compression at this point unless we are advised to do so by our vascular services after the patient has seen them. If there's arterial pain present and if there's signs of critical limb ischemia, then we need to do an urgent referral to the vascular team. If the ABPI is between 0.5 and 0.8, it can suggest a degree of peripheral arterial disease, so seek advice again from your specialist. It might be a tissue viability nurse like me or your Leg Ulcer service. So again, repeat assessment. Is there venous signs of venous disease there? Is there any signs of arterial insufficiency? But we can consider and use modified, a reduced type of compression. Is there edema present? Because we need to control that with the compression we are applying. So if the ABPI is normal, 0.8, to 1.3, then that's normal, and we are going to go full therapeutic compression. Don't start low and then try to go high because it won't work. This is therapeutic compression. So we need to be ensuring that we are applying this and getting this for our patients to improve their wound healing. We want to consider first line of using hosiery kits and ready wraps. There is absolute evidence for the hosiery kit, which was in the Venous 4 trial, and patients then are more likely to go into maintenance compression because they're used to wearing a hosiery kit, and it's just like having a bandage on. And we know then you're going to get accurate compression from the ankle upwards, and there's no room for error because it's a set compression. Assess if self-care is needed at this point as well. If it's above 1.3, and I get asked this a lot, that's saying, oh, we just can't cut, we're blowing up the cuff higher and higher and it just won't disappear, or the ABPI is above 1.3. So it might be that there's some degree of calcification in the artery, so the walls are hard. Often diabetic patients, we see this. So just check that the Doppler's been done right. Is the cuff on accurately? Have you got the right probe? Because there's two different types of probe. One is a deeper one than the other. Repeat again, but then, refer to your tissue viability or leg ulcer clinic. If there's no diabetes present, if there's no renal failure, no arterial disease showing, then it just might be that the patient needs a much higher compression than the 40 milligrams that we generally use. Because we can go 60, we can go higher than that, and we need to for some patients too. So the aim with compression is to reduce that blood pressure in the superficial veins. So there's the different systems we can see on there, the pictures of we've got the nice ready wraps, and we've got the hosiery kits, and we've also got our bandage systems. So compression is based on something called Laplace's law. Now, I'm not going to go into the whole science of this, but really what it's talking about is it's about the surface area. So the surface is the leg, and it's how we apply the compression, which then forms the amount of compression that we have. So the factors that affect the sub-bandage pressure are the tension of the bandage. So if you think we've got like short stretch ones, long stretch ones, so it's how we apply that. It's about the radius, so the size of the limb. It's about the width of the bandage, because general bandages come in a 10 centimetre width. You get some bandages that are 8 centimetres, some 12 if we're applying them to the thigh. And we always need to measure the patient's ankle because the ankle circumference in centimetres, because that can change the application of the bandage or the type of bandage that we are using, because we can then be giving too much or too little depending on the width of the bandage and the application. So it's and also can be affected by the number of layers that are applied. So we years ago the gold standard was we used a 4-layer long stretch bandage. Now we have 2-layer systems. So obviously the more layers you apply can be an increase in compression itself, and the method of application. So if we have a 50% overlap, this is going to give us 2 layers of compression. If you apply a figure of 8, then we are increasing then again that amount of compression. So if you look up Laplace's law, it'll explain that whole science behind it, but just to be aware of that sometimes you might need to pad out the ankle just to make it above a 25 centimetre, and sometimes we need to apply a smaller bandage if we've got edema in the foot, for example, so an 8 centimetre and things like that. So look to your manufacturer's information of the products. Now the beauty of having hosiery kits and wraps, of course, is there's no room for error, because a hosiery kit, we've got 40 milligrams of mercury compression at the ankle, which is graduating up the leg. That's straightforward, and that's easy to use. So we mentioned about the compression kits for Lyme, and there's, because we have got clinical evidence behind that. I know there's clinical evidence ongoing for the use of 2-layer bandage systems and compression wrap kits at the moment as well. So it's depending on that holistic assessment with the patient. Will it affect their lifestyle, the acceptability of it? Do they need to get their shoes on? Are they still going out and about? Do they want their body image? Do they want a particular looking type and colour of hosiery? For the men as well as the ladies, some things come in looking like socks. We've got some nice sheer type garments and things now. So it is really important. Just think if you're for yourself, if you're wearing these things or you're having bandages on, it is a big point for the patient. Also, other factors to include are the presence of edema, because depending on what you are using in compression terms, a short stretch system will compound edema better, so we don't get any rebound with that. Also, if you are choosing types of hosiery, then you need to look at a European class, which is a different type of knit, and that will hold the edema better too. The shape of the leg, of course, because we're having to reshape the leg with bandages before we can go into a hosiery type situation, because the leg needs to be reshapen. Pain management, we need to work with our GPs to look at analgesia if that's an issue for the patient. How much exudate is there? Do we need to use bandages initially because there's too much exudate? Or can we use some absorbent pads and foam dressings to manage that underneath like wraps and hosiery kits? And we have done that in our practice. Is there any changes to the leg post thrombosis? What's the patient's height? We had a patient recently who was so tall, and the district nurse had been putting compression. They're saying it's not, nothing's really happening with this. So I went to see this gentleman, and I said, well, he needs more compression because his legs were much longer than the general population. He was a very tall chap, big legs. So do consider that. And also for the smaller person as well. We've had some people who are much smaller in height with physical disabilities, and we've adapted compression there too. So seek advice from your specialists on that. And if patients are overweight, if they're obese, we need to look at those lifestyle health coaching type education, and because by losing weight, that will help with pressure on the lymphatic and the venous system. So the bandage systems that we have, there's different types. So there's inelastic systems. So they use what's called a short stretch. So they apply a really high working and compression and a therapeutic resting pressure, so that you pull the bandage to full stretch. I always call it rock and roll. It's lock and roll, pull it and wrap it round, and this stops the edema rebound from the leg if you have that. You can't overstretch it, which is great. And if a person, even if they can move their foot, do some leg exercises, if they're not as mobile independent as some people, then that will still activate those working pressures. But some people like it because if they go to bed at night and then when they're resting, then the pressures are not so intense, so it's a bit more comfortable. They have a high static stiffness index as well, so that's why it works well on reducing the edema. So elastic bandage systems, they're long stretch, so they apply a constant pressure to the limb, whether somebody's mobile or somebody's at rest as well. So that was like the 4-layer systems we used, and even in some of our 2-layer systems, some have a mixture of long and short stretch within them. This is an image that unfortunately we do still see, and it's a poor bandage technique. So this has either been applied in an incorrect way, and we do know that bandages must be applied from the base of the toes to 2 centimetres below the knee, or to the, we do some above the thigh as well if we have lymphedema or edema up there. But this will just cause a tourniquet effect around that mid-calf, and we can see that swelling above there, and it can cause trauma and just further ulceration. It may be as well that patients sometimes have pushed the bandage down. We get that knitting needle syndrome where people want to scratch and things, and even sometimes you have to look out for self-harm as well. And it may be that the bandage has slipped, so the bandage has been applied, the edema's reduced, the bandage has slipped, so we need to, in initial stages, maybe be just going more often until we get that edema reduced. So once the leg ulcer is healed, chronic venous insufficiency is a long-term condition, and the management of this is a condition for life. So, and again, I'm going to say, remember those referral to vascular. Some people can have that reversible intervention. So once it's healed, we need to create a new care plan if they are going to remain in compression, because this will then prevent that recurrence. So if they've had a leg ulcer in the past, obviously they're going to be at an increased risk of developing new ones in the future because they have that venous insufficiency. So it's essential that we look to compression garments that they can then maintain and manage and continue to wear. For some people, then this may be for the rest of their lives. So consider, when we're looking at the compression, what level of compression does the person need? If they have normal ABPIs, then let's go for the full therapeutic compression that we have. And how much realistically are they going to tolerate as well? Your patients, you've done that care, you've done that discussion with them, so it's individualized, tailor making it with them. And are they going to be able to apply it to is a wrap system going to be easier for them, or have they got families, carers, and people who can help and assist them to apply it? So just be aware, and you can see on the table there's different types of compression system. So we've got the RAL, which is the what we call the European class. We've got the British standard and the French and the US, but it's normally the British standard and the RAL that we use in our formularies. And so the RAL, the European ones, are the ones that really are better if you've got edema to the leg, and then the British standard if not. Now, in the absence of an ABPI, when you initially see a patient, if they've presented with a leg ulcer, and until we can get the full assessment done, if there are no signs of arterial involvement to the leg, we can apply a class up to 20 milligrams of mercury in compression and then within the 2 weeks following that, we need to complete the Doppler and that full assessment. Now, this is in best practice guidelines, and it's becoming more common within our formularies and our pathways that you will see. So there is evidence to that, and we can point you in the direction of where that is. So factors that can influence the choice of type of compression is their ability to manage it, their skin condition, because if there's something that they can remove easily and put on, then they can do their skincare regimes, washing, applying their emollients and things like that. Or is somebody going to be able to do that for them? Because you don't want somebody who's just going wearing a garment for a week, 2 weeks until somebody comes in to change that, because the skin's going to get very dry under there and cracking. The shape, the size and the function of the leg, what's their walking ability, have they got fixed ankle joints, things like that. Again, the small, the tall patient, how much compression do they need? And their arterial status, so it may be that we're going to a reduced compression rather than full. And any other medical conditions, have they got sensation loss? Is there peripheral disease there to them? Have they got neuropathy? So it's, all arthritis, are they going to be able to actually physically, apply these garments? So lots to think about. So their age, their dexterity, and their lifestyle, some people still going out dancing at 70, and why not, but also as well, we've got end of life, and is it, we often do palliative symptom management, so we can still use compression at this point as well. So these are some of the supportive aids for patients and their carers in applying hosiery. So we've got the device with the handles, which is called Steve. I don't know why it's called Steve, but it is, and I'm reliably informed this is a fantastic device that patients like. We've got the ActiGlide in the middle, which is a bit like a parachute type material. We've got the general hosiery stands where you put the hosiery over it and then you put your leg in. We've got the Rolly, which is one of my favourites. If you've never tried that, you can prescribe these, have a go. I think the Rolly is really quite easy to for applying a hosiery. And then the rubber gloves, the gardening gloves, because you can get a better grip, so then we're not getting clipped skin with nails and things like that. So make sure we inform our patients about the red flags, and for staff we need to be aware for that cellulitis that we saw that image there before, any osteomyelitis that we know is present. Sometimes if somebody's had osteomyelitis, we can get sinuses and it continues to leak and things, but they would need imaging to diagnose this. If anybody has sepsis or necrotizing fasciitis, so this can come on really quickly. We seem to have an increase in necrotizing fasciitis often in the winter, and then the patient will feel unwell, there'll be skin changes and can be necrotic very, very quickly. It can occur it's a bacterial infection, and it can occur from all sorts of things, even sometimes just from scratch on a rose in the garden, something like that. But this is an urgent A&E referral, because these people will need often to go into theatre to have this surgically debrided. If there is signs of critical limb ischemia, we need to refer urgently to the vascular services. So if there's necrosis to the foot, the leg, any changes in skin colour, temperature, pain as well, increase in pain. And suspected malignancy, if something's just not quite right, it just looks unusual, then we can refer to dermatology and they can do skin patch or biopsies to confirm anything like that. So if the leg changes in size, say if you've got one leg that swells up, it may be DVT, things like that. So anything that's a little bit different. And then the ABPI below 0.5, we want to refer onto vascular there, because there's presence of peripheral arterial disease. If we have an ulcer to the foot below the ankle, and if the patient is diabetic, then we need to be referring to the diabetic foot ulcer specialist, because quick, swift action is very important for patients with this condition. And anything atypical, you've got a funny coloured edge, it might be a pyoderma gangrenosum, there could be all sorts of other things going on. So anything kind of outside of the normal scope of practice, just seek advice. We are an MDT team and we should be working closely together. Many of you will all of you will have come across some patients who, they for some reason they will refuse the treatment. They'll say that treatment's not for them. Or they start something and then they don't want it, and we put a label on this. We kind of call it non-concordance or non-adherence, and I think we have to really look at this. It's really important, and we need to ensure that we've got a trusting relationship with the patient. Is there any issue between the patient and any particular staff? We need to make sure we've got a really trusting relationship built up, because we want to understand the problems that the patient has, and we need to explore this too. So has the treatment fitted into the patient's lifestyle? They've got to utilize and wear these things and put up with this leg ulcer or this edema every single day. So the treatments we're advising and putting into place does it suit with them? Is there somebody in the family or a friend or a neighbour who's got a real interest in their progress, in helping them to improve, who may be able to get on board to speak with them and motivate them? Does the patient accept that the treatment can control their symptoms? Do they understand what the condition is that they've got, and how this will then help to improve their venous return, for example? And have we taken steps to manage pain? Because that may be the underlying issue, that it's just too painful and they just can't bear the thought of a bandage or the compression onto their leg. So health coaching is a term within the NHS now, which is part of the 10-year plan. So you'll hear this more and more. So it's taking that person-centred approach in that assessment and care planning. So we're creating a relaxed, non-judgmental type environment. We want to assess the patient's educational abilities, willingness to learn, and that understanding of their condition. So we can implement motivational interviewing strategies and techniques with them in their care plan. And then to reinforce all that knowledge with some verbal information, leaflets, videos that we have on like the National Wound Care Strategy website, or you may want to make your own types of videos too. So they're aimed at the patient's educational level. So that comes to the end of my presentation. I want to thank you so much for being here with me for this watch party. I hope you found it useful. I love talking about this subject. So I'm going to stay around to answer questions for the 15-20 minutes. I'm sure there's elements that I've missed that you've come up with, or we can talk about further. So I want to thank Flen Health for this evening's session. If you would like information on Flaminil and how it works, or see the evidence on its safety and effectiveness, please visit their website. As I mentioned earlier, Flen have a number of the hand hygiene tools to give away to nurses, so I'm sure you'll find them helpful. So if you want to get hold of one, you will just need to go to the website address on the screen now, which we can also share with you in the comments. So thank you so much for watching. Have a fabulous evening, and I'm sure I will be speaking to you, seeing you soon.